Okay, so we have our next speaker, Professor Sinead O'Keeffe from University of Limerick, with the talk Inclusive Dosimetry, Optical Fiber Sensors for Radiotherapy, Dosimetry in Pelvic Cancers.
Thank you very much. And thanks to all the organisers for inviting me here today. So I was invited to present my research in optical fibre sensors for radiotherapy dosimetry by the Women in Sensors. So I took kind of that inspiration to add a little twist to the presentation. So alongside all of the technical kind of and results that we have, I've also included this inclusive dosimetry. So how we went from developing a sensor for prostate cancer in men to advancing it towards gynecological cancers. And so it's covered completely in this area called pelvic cancers. So the work I'm presenting is part of the European funded Origin project. And this brought together a number of universities and hospitals and industry partners to develop optical fibre sensors for pelvic cancers, so specifically prostate and gynecological cancers. And so while we were creating and developing the proposal, everybody within the group at that time was focused on prostate cancer. So all of our research and our sensor development to date was focused on prostate cancer. We were working with oncologists that were treating prostate cancer. But there's always this question in the European funding calls, how are you addressing the gender dimension? So obviously, if your research is completely focused in prostate cancer, it's very difficult to address this question. So we were like, well, why are we focusing just on prostate cancer? Why don't we expand it to gynecological cancers? So we brought in some new partners that had experience in gynecological cancers, and we also hired a clinical fellow who's a radiation oncologist in gynecological cancers. And so with that, we worked kind of really intensely at the start to understand the workflow, the differences that these sensors would need to make. So looking at cancer in general, there were over 19 million people diagnosed with cancer in 2022. And that number is increasing every year. So with pelvic cancers then, as I said, it's divided into prostate cancer and gynecological cancers, which cover endometrial, ovarian, cervical, vulval, and vaginal cancers. And with that, up to 50% of cancer patients will receive radiation therapy at some stage during their treatment. This can be in the form of a monotherapy where they're just receiving the radiation therapy, or combined with other forms of cancer treatments. So radiation therapy produces high energy ionizing radiation, which damages the DNA of the cancer cells, preventing them from dividing and growing further. And the main aim of radiotherapy is to maximize the amount of radiation delivered to the tumor while minimizing the exposure to other kind of healthy nearby organs at risk. And radiotherapy is divided into two broad areas. We have external beam radiotherapy, which is delivered external to the patient in the form of linear accelerator or proton beam. And then we have internal radiotherapy, which is known as brachytherapy, where we have the radioactive sources being inserted directly into the patient. And this is the form of treatment that we're focused on. So within brachytherapy then, we've got two broad areas. We have high dose rate brachytherapy, where we have a single radiation source that's attached to a wire driven by what we call an afterloader. And that has a really high dose rate, and it's passed through catheters along this needle in steps that we call these dwell positions. And so you have this single source moving to the catheter, and importantly, this source is removed at the end of the treatment. On the other side then, you have low dose rate brachytherapy, And this is where you have between 60 and 80 seeds that are permanently inserted into the patient. So this one is used primarily for prostate cancer, have been the focus of most of my research up until this project. And the other one, the high dose rate, is used for both prostate and gynecological cancers. So when we're looking then at the need for dosimetry, there are currently no commercially available dosimeters used for brachytherapy. So what they do is they perform a scan on the patient in advance of the treatment, and they model the radiation dose that would be delivered to the patient, assuming that the source is placed in a certain position. The issue with this is that it's performed several hours in advance of the treatment, and in some cases it can even be a number of weeks. So the assumption is that the organs at risk don't move. So what if this is not the case? So the clinical fellow that we had within the project looked at these cases. So she moved the applicator in the models to say that, if we move it in 1 millimeter shift, what is the impact on that on the dose being delivered to the patient? So just a 1 millimeter shift will increase the bladder and rectum dose by up to 5%, and only just a 6 millimeter shift can increase that dose by more than 40%. The other issue we looked at is what if the organs themselves move? And so with this, we looked at a retrospective study of a number of patients, and we saw that up to 50% of treatment courses had to be altered because the dose was being delivered too high in the first round of treatment. And this meant that the radiation dose being delivered to the target area is not optimal. So there's a real need for dosimeters to monitor in real time these radiation doses. So optical fiber sensors lead themselves really well to this application because they're small size, lightweight, flexible. They provide that real-time monitoring. They're easy to handle, they can be multiplexed, and they're electively passive so that they can be safe for insertion into the patient. They're waterproof, they're unperturbed by magnetic fields, and the materials that we're using plastic, PMMA-based optical fibers, so they have a near tissue equivalence, which have additional benefits for these medical applications. So our sensors are based on radioluminescence, where we have a scintillating material at the tip of the fiber. This can be either embedded into the core of the fiber or attached as an additional tip. When it's exposed to ionizing radiation, it gives off light which travels through the optical fiber to the photodetector, and then we monitor that light signal over time to give us the accumulated dose being delivered to the patient. So looking then at the clinical considerations for in vivo dosimetry, first of all, I'll look at prostate cancer and just show you the treatment and where we have our sensors placed. So we have, so you have here a number of needles that are interstitially placed into the prostate that's used to deliver the radiation sources into the prostate. We can place additional needles to take our optical fiber sensors. There's also a Foley catheter that's placed in the urethra, so we can insert a sensor bundle into this area, so we can have a number of sensors along here. And we have a transrectal ultrasound probe that is inserted for monitoring during the treatment, and we're able to put additional sensors here. If we look then at the gynae cases, we have a single applicator that's placed into the patient, and that just has a single radiation source that goes in here. Occasionally, they'll have an additional ring that they can place interstitial needles into the cervix area. They'll also have a Foley catheter placed into the urethra, into the bladder, so that we still have that option to be able to provide additional sensors into this region. But importantly, there isn't that transrectal ultrasound probe, so currently there's no way of monitoring within the rectum. And to place something as large as a probe that we would with the male patients would bring that rectal wall too close to the radiation area. So we had to come up with a different method for monitoring the rectum. So we have a number of different kind of areas then that we have to place. As I said, within the prostate, we can use the additional needles. We place between 1 and 3 sensors into the prostate volume, depending on the volume of the prostate. Within this area, the stability of the sensors is really important. So we developed these 3D securement devices here that were able to clamp to the end of the needles to lock the sensors in place. For the urethra, then, we have a bundle of 3 optical fiber sensors. And again, we have an additional 3D printed clamps that you can see here to ensure there's no leakage from the bladder. For the rectum then, so for the transrectal ultrasound probe for the males, we're able to develop a sheath that goes over that transrectal ultrasound probe and place up to 9 sensors to monitor that rectal wall dose. For the gynae cases, then, we use an additional Foley catheter, similar to our urethra probe. Additionally, then, we're able to look at the monitoring within the cervix. So we use what we call a tulip applicator, which is a 3D printed applicator that allows additional interstitial needles to be placed into the cervix. And so this allows us to place, again, up to 1 to 3 sensors into the cervix area. So look then at our clinical constraints. We have the various things, but really what limited us was the Foley catheter dimension. For men, the maximum diameter is a 14 French Foley catheter. So this would have an inner diameter of the port opening area to allow our sensor to pass through was 2 millimeters. So if we wanted to have the 3 optical fiber sensors in here, it limited our sensors to being a 500 micron fiber sensor with an outer jacket of 1 millimeter. So we also worked with the clinical fellow in developing the actual position along the urethra and along the rectum as to where exactly these sensors should be placed based on kind of retrospective analysis of the doses and the problems that patients were experiencing. Where were the main high doses that were unexpected? So I'll move then on to the sensor design. As I said, we're using this radioluminescence, and we worked with the VUB in Brussels, Francis Berkman's group, looking at the optimization of the sensors for mass manufacturability. And so they developed the system where the scintillator is doped with the PMMA material, and they developed a disc. So with that disc, then it uses compression molding technique to develop these individual sensors around here. So you can't really see it, but within each of those red circles, there's the tips of the fiber. And then these tips here are aligned with the optic fibers and glued in place. And if anyone is interested in the actual sensor development, I'll refer you to this paper here. So next we have the photon detection system. And this is really kind of determined by the scintillation characteristics, especially the light yield and the decay time. So in the case of the materials used for origin, we have a really long decay time. So this effectively means that we're diluting that scintillating light. So for every interaction, we have kind of a trail of single photons. The advantage of this is that we have kind of that multiplication factor. So for every gamma ray, we have multiple photons coming out. But on the other side, then, we have that need for a single photon sensitive device. So with that, we selected the silicon photon multipliers. And particularly for this system, we had a key tech SIPMs. And so we have an array of the SIPMs and a Kane FERS board for the readout system. So this then just takes an example of one of the sensor readings as for the HDR system as the source is moving along the catheter towards the sensor, so as it gets closer. So we initially have this dark count rate, and as the source is moving closer to that sensor, you see this increase in the signal that we're receiving. And so we're measuring these individual responses and that will then give us the dose readings. So looking then at the gynecological cases, we've developed a phantom that allows us to just test the cases for the female patients in a water phantom. So we have a 3D printed phantom that allows us to place our sensors in the position that would be the bladder and the rectum. This here is where the source would pass through these 5 different dwell positions here. And this then is a scan of the phantom with the fibers marked in place here and the source positions here. And then this is your isodose profile here. So we compare then the measured dose that we have from our sensor and compare it to what we would expect from the treatment. So we get good comparison for our sensors for this application. Looking then at the prostate treatment, we have a 3D printed anthropomorphic phantom where we're able to place inserts and optimize the patient anatomy for and the sensor positions for it. So looking then at, we developed a full treatment plan for the phantom and looked at how our dose rates compared to the treatment plan. So what we have here is we have 13 catheters placed into the prostate and 2 additional ones hold the fibers. So here we have the different needles, the catheters for the sources, and then we have additional sensors then are placed in these different areas here. So this is our actual treatment plan compared to, so these are the clinical constraints that you're intended to kind of remain within. And you can see here that the plan isn't ideal. We shouldn't be at these levels. We should be within the levels that are indicated here. But as it was only just kind of for demonstration, it was sufficient for us at that stage. So here you can see the results as the source is moving through each of the individual catheters. So you have each of the individual catheters here, and then it moves in steps. So if we zoom in on that area here, you can then kind of see the actual profile of these steps. So just depending on the location of our fiber relative to the catheters, we get some really high responses and some much lower responses. And then depending on the sensor, you get that variation and that distribution of the dose. So this just shows kind of the response of the sensors compared to what was actually determined by the treatment planning system and what we actually received. So you can see that we do have deviations of up to almost 15% for certain cases. And so we use the information from these radiation doses to do a source localization. So we'd use trilateration to allow us to kind of pinpoint where the sources are located. I don't have time to kind of go into the actual algorithms around that, but so with that information, we're able to determine the actual radiation sources as opposed to what was planned. and develop a new plan to give this full deviation. So the top one here is the original plan. This is how it was actually delivered. And you can see here then the constraints, the original plan, and this is what was actually delivered. And what you see is that the radiation sources, so the needles were actually shifted slightly towards the rectum. And so with that in mind, you're getting, so here, you're not getting the dose that you want delivered to the prostate, to your tumour, but you're getting an increased dose to both your urethra and your rectum. And so it really just indicates the importance of measuring in real time the actual dose that's being received and not just what's being perceived, because as I said at the start, it's these small little 1 millimeter shifts have a huge impact on the actual radiation dose being delivered. So just then to summarize, we've shown that optical fiber sensors are really uniquely positioned to provide in vivo dosimetry for brachytherapy. And we have that sensitivity, as I've shown, for HDR, for prostate and gynecological cancers. And then just that it really does require that close collaboration between the clinical teams right from the outset to develop these sensors that they can be easily integrated into a clinical workflow. And you know, I would have, at the design stage, had weekly meetings with the clinical teams and the clinical oncologists, particularly for the gynae, because it was new to us, to really learn how that system could be integrated into that workflow without impacting that workflow. They're very clear in the hospitals that, you know, you can add 6 minutes to our time and no more. So if you want to integrate any kind of new system, it has to be within their existing workflow, no matter what the benefits they see of it. But I think it just shows as well then that we have that you need to consider the sex-specific anatomical and physiological differences right from the very start in your sensor designs. If you don't take that, if you start and you just look at one sex, you're not considering the workflow for all situations, and it's very difficult to go back and try and integrate it into a new workflow. So really for what we've found is now, while we originally started with prostate cancer, gynecological cancers have opened up a whole new area for us, and a really important area, obviously for the women receiving the treatment, but for our research area to further develop, because HDR brachytherapy is really, really important treatment modality for female patients undergoing cancer treatment. So just ensuring that that inclusive designs benefits everybody, and that it does open up these new research opportunities. So with that, I'd just like to thank all of the team that was involved in all that research, and the funding bodies, and I thank you for your attention.
So thank you very much for your talk. We have time for 1 or 2 questions from the audience. Yes. Anyone?
Very, very good talk. Thank you for that. I was wondering, you're placing the PMMA fibers. Is there any chance you're close to the tumors or the regions where the treatment is actually happening? And are you planning to measure any tissue property optically? Obviously, I'm asking that question, yes.
Yeah. Yeah, and certainly tumor hypoxia. Thanks. Yeah, so it is one of our intentions to look at combining the tumor microenvironment with the radiation dosimetry at the same time. So we do insert directly into the tumor. And we have looked at hypoxia to some degree, but I think we might have more conversations around that area. Yeah, it's certainly, I think it's a big area to be able to measure the tumor hypoxia at the same time as delivering the radiation. So tumor hypoxia has been shown to make a tumour more resilient to the radiation dose that it's receiving. So if we can measure the tumour hypoxia at the same point of where we're measuring that radiation, in that at real time they can say, oh, you know, it's very hypoxic, let's give it a little bit of longer time with that radiation treatment at that time. So there's definitely huge scope there to combine them.
Any other question? No, so please let's thank the speaker again.
Thank you.